Great. So greetings, everyone, from the Stop2B partnership, and welcome to this webinar on Truenat External Quality Assessment Information Sharing. My name is Wayne Van Gemert. I'm a Diagnostics Technical Officer here at the Stop2B partnership, and I'm the lead for the Introducing New Tools project. I am co-moderating today's webinar with Kaiser Shen from USAID.
Hi, everyone. Kaiser Shen. I serve as the acting TAP case finding team lead at USAID. We're happy to have everyone online today for the Truenat EQA webinar. As part of our USAID Stop TB and IDDS joint project, we've supported 9 countries with at least 1 year of EQA for Truenat in collaboration with SmartSpot Quality from South Africa. Now the countries have completed all 3 cycles of EQA. This webinar will summarize the results of this program, create a platform for countries to share their experiences in EQA implementation, and share insights and best practices learned from the implementation of EQA for countries seeking to introduce similar programs.
Okay, so we have 5 exciting presentations lined up for today. But first, just a few words about housekeeping before we begin. So the speakers have been asked to present for no more than 10 minutes so that we have some time at the end of this 1-hour webinar for Q&A. But in the meantime, please, all participants, feel free to use the chat box to ask questions as well as share your own thoughts and experiences. So without further ado, we're going to ask our first speaker to present on the first topic. This will be Eric Reisdorf, who's going to give an introduction to the IDDS EQA program. Eric is a senior manager, diagnostic networks at USAID's IDDS project since 2021, supporting the TB program where he leads the new diagnostics tools support team. He has significant experience working in public health laboratories and with global public health laboratory strengthening programs. And he has participated as a subject matter expert and provided mentorship, training, and technical assistance for USAID, CDC, and APHL programs. So, Eric, the floor is yours.
Thank you, Wayne. Good morning, good afternoon, good evening, everyone. It's great that so many of you could join this webinar today. I've heard that there are over 400 registered, so excited to see so much interest in the EQA programs. So again, if you could advance the slide. Okay, so the USAID funded Implementing New Tools project, or iNTP, was the first multi-country rollout of the Truenat instrument in 9 high TB burden countries in South Africa or Southeast Asia and in Africa. IDDS collaborated with the Stop TB partnership to support the implementation of 300 Truenat instruments in these countries. The Truenat instruments were primarily implemented at the peripheral level facilities, and these facilities are mostly staffed by microscopists that have little or no experience with molecular diagnostic tools such as Truenat or GeneXpert. So we learned that many of these end users were originally not sensitized to the EQA process from our pilot rollout of the EQA. So as a solution, we developed a training package that we could train the Truenat super users who are from in-country national laboratory staff with molecular diagnostic expertise to support the sites with EQA testing and reporting, as well as to follow up with them for troubleshooting and helping implement corrective actions at the sites after each cycle of the EQA. Next slide, please. So what is external quality assessment, or EQA? EQA is a method that allows for comparison of a laboratory's testing with a reference source outside of the laboratory. It's really an independent and unbiased assessment of an individual laboratory's performance. Test results are reported by each testing site and compared with the reference results. That includes well-characterized TB reference strains, including those with RPO mutations that confer RIF resistance. In some cases, commercial vendors with large schemes can provide performance reports that include a comparison between other manufacturers' tests and methods. Some of the common EQA schemes below that I've listed include sample rechecking, which is typically a blinded panel of samples that are rechecked by microscopists. Also common is interlaboratory comparison, where samples are exchanged between laboratories. And we typically see this in countries that don't have a large national program for EQA. And lastly, what we'll be talking about mostly today is proficiency testing, or PT. And you can see here the graphic on the right illustrates the EQA process. Next slide, please. So why is EQA important? Again, EQA provides that independent, unbiased assessment of a laboratory's performance. And it's also an essential component of the quality management system and is included as one of the 12 quality system essentials that by WHO that I have displayed on the graphic on the right. It's also required for laboratories that are seeking ISO 15189 accreditation. So there are, of course, many benefits to participating in EQA, and I'm not able to include all of those, but some of those that are important include is that it ensures that the testing is done in compliance with the diagnostic algorithm and that SOPs are followed. It helps ensure that the end users are competent. It helps ensure that the test system is quality assured and ensures accuracy of the test results. And it instills confidence by both doctors and patients and other stakeholders in the validity of the test results. And also it helps determine if there are gaps in any of the 3 phases of the diagnostic testing. So it really provides a good opportunity to look at both the pre-analytical, the analytical, and the post-analytical phases of testing to see if there are gaps or challenges within those test systems. And lastly, it's really provides an early identification of low performing laboratories that can be supported through super users, through intensive mentorship to ensure continuous quality improvement. Next slide, please. So as many of you may remember that when GeneXpert TB testing was first rolled out about a decade ago, there were no providers of EQA, so the testing that was implemented was not quality assured. So we learned from this and decided that it was beneficial to provide EQA panels to coincide with the implementation of Truenat testing as part of the iNTP project. After some searching, IDDS contracted with SmartSpot Quality in South Africa, as they are a well-recognized and internationally accredited provider of validated Truenat MTB and RIF EQA panels. The program was designed to be a short stopgap support of EQA until national TB programs or other stakeholders can build capacity to produce their own panels. Of course, the program had to have flexibility for each cycle, and as far as the deadlines, as implementation of the Truenat in many countries experienced delays. Each EQA panel consisted of 4 samples, each with a unique sample ID that was on as a QR code, so that labs were not able to share results with each other. There are 4 dried culture spot samples per panel, also known as DCS, and it consisted of a combination of MTB and non-tuberculosis mycobacterium samples as reference strains. These DCS samples were inactivated, so they're non-infectious. They contain quantified intact microorganisms. The real benefit here is that they could be shipped as non-hazardous material, typically which was done in a plain brown envelope for direct centralized delivery. And fortunately, in our experience, they had not been subject to any customs fees from the countries that we worked in. 3 cycles of EQA per year were all included in one shipment to keep the costs low. And the DCS panels can be stored at ambient temperatures, so no refrigeration is required at the sites or for shipping. And these were delivered to the laboratories mainly using the already established sample referral systems that were in place. The panels are stable for up to 24 months, and IDDS provided 225 panels to the 7 iNTP countries that are listed to the right that chose to participate in the program. Next slide, please. So this slide illustrates the laboratory aspects of processing the DCS samples once they arrive at the laboratory. I wanted to point out the initial processing of the DCS samples. It's critical that the samples are to be incubated and swirled vigorously according to the SOP, so that sufficient amount of the mycobacterium in the DCS samples are released into the liquefaction buffer. Having this step done correctly is important as it helps avoid invalid or other indeterminate results. After it's processed in the liquefaction buffer, that's transferred to the true prep cartridge where it's extracted, the DNA is extracted. Then the next step is the eluted DNA is mixed with the PCR buffer, transferred to the chips. And if positive, the site should be reflexing the testing to the RIF test. Lastly, the results are downloaded to a .csv file, which is uploaded to the SmartSpot Monitor website, which can be done through either the web portal or through the mobile phone application that's also available, along with the test result interpretations by the end user. The results are then analyzed and reports are issued, both group reports and individual reports that are issued to the sites and are also available for download from their website. Now I'm going to turn over the presentation to my IDDS colleague, Han Lei, and she will take us through the results of the 2022 EQA program. Thank you.
Thank you, Eric, for your presentation. So as a reminder to everyone, please feel free to use the chat box to ask any questions. As Eric mentioned, our next presenter is Han Lee, who is going to provide a summary of EQA performance under the IDDS project. Han is a TB program coordinator at USAID IDDS project. She has a master's degree in global health epidemiology and disease control from George Washington University. Since 2022, Han has provided technical, logistical, and administrative assistance to the Truenat rollout through IDDS under the Introducing New Tools project. Over to you, Han.
Great, thank you, Kaiser. So first, I will start by presenting to you how the EQA results are calculated by SmartSpot. So for each cycle, each site will receive a panel of 4 controls, and a correct result of each control will equal to 4 points. A correct MTB result is 2 points. A correct RIF result is 2 points, and partial answers such as indeterminate or invalid result in a 1 point deduction. And based on the raw points, a percentage score will be calculated, and this percentage will indicate an equivalent site performance outcome. You can see I will use the term pass, acceptable, concern, and unacceptable throughout this presentation. So here is the summary of the panel composition in 3 cycles of 2022. For the first cycle, all control in the panel include 1 type of the MTB bacteria without rifampicin resistant. In cycle 2, we were introduced to a mix of non-MTB, MTB, and RIF resistant MTB in the panel. And in cycle 3, we see the introduction of lower concentration of bacteria available for testing. And here is the participation and test rates across all countries in 3 cycles in 2022. On average, about 90% of the distributed panels were tested and have their results reported back to SmartSpot for analysis. And as you can see here, that there's an upward trend in reporting because with the super user program, super users will provide assistance to the sites and help with the result reporting. Here is a summary of the average scores across all countries in 3 cycles in 2022. As you can see here, all countries passed the minimal target performance benchmark of 80 percentage point, and about half of the participating country reached the past performance indicator that SmartSpot provided. And given the novelty of the assay, the performance was positive. However, we can definitely see that more training assistance are still needed for all participating countries and sites to reach past performance in other EQA cycles. And here is another look of the performance summary outcome. As you can see here, the number of sites achieving a past performance went down from cycle 1 to cycle 2 and 3, as cycle 1 were the easiest cycle. However, across all 3 cycles, the majority of all the sites still achieve pass or acceptable performance, and the average score of all 3 cycles are above the benchmark of the minimal target of 80 percentage point. And here is the summary of the incorrect results across all 3 cycles in 2022. Some possible causes for these incorrect results can be not adhering to the SOP, not following the diagnostic algorithm, some end user errors, low efficiency of the Truenat assays in detecting certain RPOB RIF mutation. And I want to draw your attention to the 2 most common incorrect results in last year EQA, which is false negative for the RIF test and the RIF indeterminate result. And these 2 common incorrect results really highlight the importance of following the SOP and letting the control to be incubated for a sufficient time. Because sputum needs to be properly liquefied to release the bacteria to provide correct results. And in conclusion, across all 3 cycles, 89.6% of the distributed EQA panels were tested and submitted to SmartSpot for assessment. The successful submission rate improved over time, and this is definitely with the assistance of super users throughout the reporting cycles of EQA. All countries met the minimum performance benchmark of 80%, have met the pass grade or 90% for EQA results across all 3 cycles. The most common incorrect results are RIF indeterminate and RIF false negative. After each cycle, IDDS debrief in the countries, and super users utilize the EQA results to follow up with underperforming sites and increase mentorship to improve performance. And here's a summary of the challenges that we met throughout the implementation. Some of the points have been mentioned throughout the presentation. I want to draw your attention to some other points here. The challenges of EQA implementation were that end users were not sensitized to the molecular EQA programs, which lead to some unfamiliarity in beginning of the activity. Delivery of the panels to remote areas can be difficult, and cycle deadlines were inconsistent in each cycle, site, and country due to delays for various reasons. This led to a lot of challenges in following up and managing the activity. And here are some of the lessons learned. Because of the inconsistency in the internet, we see that in-person training on EQA really helped improve participation and performance. We have short training videos that we disseminated throughout social media to help with as a training supplement and troubleshooting. The translation of the instruction for use of the EQA panels to the local language really increased end users' understanding of the process. In 2023, Truenat added an exporting CSV function to improve with the results reporting and provide additional technical details for analysis. And the debrief after each cycle really helps the super users to provide additional mentorship to underperforming sites. And that is the end of our presentation. Thank you for listening.
Great, thank you very much, Han, for the presentation. I see in the chat box the question, will the presentations be shared? So yes, we will be sending after the end of the webinar a link not only to a recording, but also so that you can have access to these slides. Our next presenter is Dr. Thor Shante. Shante is the IDDS Cambodia team lead. He has over 24 years of experience in the health sector of various institutions, including the government and both national and international NGOs. He has led various community and facility-based initiatives for TB treatment and has also contributed to developing multiple policies and guidelines for TB, HIV, and malaria programs in Cambodia. So, Shante, the floor is yours. Han, we no longer see the slides, however.
Thank you, Ines.
There we go.
Go
ahead,
yes.
Shante.
Okay, sure. Thank you. Yes, I'm Tajan Tas, IDDS Cambodia team lead. So I would like to, I starting in this evening. I have a chance to present the experience of the EQA experience in Cambodia. So next slide, please. This is the picture showing the has the staff at the peripheral health facility performing the EQA test in 2023. Next slide, please. Next slide, please. Yes, this is the location of the Truenat site in Cambodia. We placed the 15 Truenat machine across the country within the 11 operational districts and 5 provinces. And this is the step of the implementation of the Truenat in Cambodia. We have conduct the consultation workshop with the national program in May 2021, and we procure the distribution of the Truenat instrument in February 2022. And we have conducted training and installation of the instrument in at the site from February to March 2022. And we got a green light from the national program to implement the Truenat testing at the site in May 2022. And we joined the EQA program in 2022 as well. And in from the implementation of the Truenat timeline is from May to November, and then we collect the data and analyze the data and making the report for the national program scaling up. Next slide, please. Yes, this is the process of the implementation of Truenat EQA in Cambodia, especially in 2023. The timeline that's set by the Smart Spot is cycle 1 2023 in June, and cycle 2 in August, cycle 3 in November. And actually we received all 3 cycles in let's say this mistake of our team. I suggest to update after the presentation. This we received the cycle 3 cycle in June, and distribute the cycle 1 and cycle 2 to the site in July, and cycle 3 in October. And the agreed test date is cycle 1 is in August, cycle 2 in August, and submit the result by the end of August as well for cycle 1 and cycle 2. And for cycle 3, we test in November and submit the result by the end of November. And so far we have received the result report from Smart Sport system for cycle 1 and cycle 2 in September. As you see the result, summary result in the right hand. We include the cycle 3 of 2022 into this chart for your comparison as well. For the cycle 123, the performance of the test is very low, and in cycle 3 2023, the performance of the staff at the site improved. Mean that 14 site amount 15 site passed and only one site acceptable. The low performance of the cycle 1 may related to the interrupted of the test at the site due to the chip expire, and we waiting for the fresh chip a long time as well. Let's say that we just get the fresh chip in by mid of August. Therefore, the EQA test is cycle 1 in August when we set the date is in June. Next slide, please. This is the best practice we have learned. The translating of the guidance into the local language is made easy for the end user to understand and in the testing process. And we have created the video for the EQA testing process and how to export the EQA result in CSV file and share video to the end user as the additional guidance for them. And we established the Telegram group platform for the timely supporting to the end user, including follow up and get the result on time as well. And we share the EQA result report with all relevant users, include super user at the national level and the end user on time to let them know their performance competency and take the corrective action on time for improvement. Next slide, please. This is the challenges that we faced so far. The first point is limited IT skill of the super user that they cannot input the result to the EQA system. And the solution, our focal point collect all the result EQA testing and enter into the smart sport system, and we will continue to support the site and the super user until the end of our project by December 2023. And the second point of the challenges is the EQA result file is not compatible with the ISO system. It means that this file cannot use the ISO device to export from the Truenat device. So the end user use the Android system out the coworker to export the result. And this is mobile diagnostic have been informed to resolve the issue. And the third challenge is difficult to provide remote support to the site because our Truenat instrument have no computer attached. They allow us to log in directly from the remote system, remote distance. So this is the very difficult to support the site right now. We stay far away from the site. And the insufficient training for EQA testing to end user is the big challenge for us. This not because of the smart sport, but because of the end user not familiar with the English language and the IT knowledge as well. So this cannot provide the insufficient of the EQA testing. And the last point of the challenge is related to the sustainability. We are concerned on that because national program has confirmed that they have no budget, enough budget to support the EQA program after the IDA finish the project. So we have discussed with Truenat and inform about the EQA program and request Truenat to work closely with Smart Sport after IDA close out in Cambodia. Please, next slide, please. This is the lesson learned. We learned that the close coordination with the CNAT and is crucial to ensure the timely distribution and conduct the EQA panel testing, not only for the EQA, but for the chip and the cartridge of the Truenat as well. And we learned that remote guidance from the super user improves the competency of the end user. And the Telegram group or social media platform is the best way to communicate with the end user and timely support and respond to the site. And the EQA testing result is not fully representative of the performance and competency of the operator. So the routine collection and analysis of the key performance indicator is and on-site supervision is required for the this program. And we learned that the Truenat EQA program is feasible unless there is funding support from donor. So I stop here because it's all from my presentation. And if you have any question, please. Thank you.
Thank you, Chante. So it looks like we have a couple of questions in the chat. Let's hold off on those until the end. We will hopefully have some time then. So our next presenter is Herbert Matunzi. Herbert is the IDDS Zimbabwe team lead. He is a highly experienced public health specialist who specializes in TB laboratory work with more than 20 years of post-qualification experience. Previously, he worked as National TB Laboratory Coordinator for the Zimbabwe Ministry of Health and Childcare National TB Control Program. Over to you, Herbert. Thanks.
Yes, thank you, and good morning, good afternoon, and good evening, colleagues. I will be presenting on behalf of the Zimbabwe team. Thank you, and next slide, please. So this is basically our presentation outline, looking at the background in terms of Zimbabwe, the location of the Truenat sites, implementation processes, our performance for focusing on the 2022 cycles, best practices, challenges, and the lessons learned. Next slide, please. So Zimbabwe is a country with an estimated population of around 16 million. There are 10 administrative provinces, which are 2 of them are urban, and these are also subdivided into 63 districts. And in each district, we find at least 1 gene expert machine, and there are over 230 sites that are offering microscopy site services, with 2 reference labs located in the urban provinces, Harare and Bulawayo. So we also have the 20 Truenat instruments that are located in 20 sites. And in terms of our TB profile, we have an incidence rate of 204 according to the 2023 Global TB report. And in terms of estimated proportion of TB cases with MDR or RRTB as of 2022, 1.7% and 20% new and previously treated cases respectively. Next slide, please. So this slide is basically showing you the distribution or the location of the Truenat sites. And these are in 7 rural provinces, focusing on the remote sites, mainly the microscopy sites that we're offering only microscopy services. Next slide, please. So in terms of how far we implemented Truenat, we started off having discussion and consultation with the MTP and HRIO, dating back as May 2021, when we informed about the project, and we also adopted and customized the Truenat training modules that were also indicated by Eric. And installation and training of end users was conducted in December 2021. This was also followed by a super user training in March 2022, hoping that these will be able to support their respective sites. And we also had end user refresher training during the same month. And when we then got enrolled in the Smart Spot EQA, there was also a virtual training of the end users. But unfortunately, like you have heard from the other presenters, the participation levels were low because of internet connectivity. We also then supported the super users to conduct on-site and remote mentoring and troubleshooting. And of course, the distribution of these EQA panels was done through various means, looking at the postal services and the integrated specimen transportation systems mainly, which actually helped in terms of distributing the panels to the sites. Next slide, please. So this slide is just showing us the performance from cycle 1 to cycle 3. And the scoring criteria was discussed earlier on. What we see is the submission rates actually improved, but the last cycle, that is cycle 3, we had some challenges. Well, this was done towards the festive season, and most of our microscopy sites are manned by one person, and during that period, some actually go on annual leave. And also the issue of internet connectivity actually limited the submission of the results. And our performance was suboptimal, but this then triggered the continuous support from the super users and the refresher trainings. Next slide, please. So in terms of our best practice, we see that training of super users actually helps in terms of guiding the end users and their day-to-day performance, and even during the running of the EQA panels, and also retraining or refresher training of super users, of end users, sorry, to better understand the testing process actually is one of the best methods of improving performance. And we had the WhatsApp group, which actually helps in terms of remote support for the end users. And the mobile agent is actually part of this group, and it also provides remote support when the need arises. And sometimes the reporting of the results was done via WhatsApp for sites with poor or limited internet connectivity. And the quarterly support or mentorship visits by supervisors here actually improves performance and even the testing levels in terms of the workloads. Next slide, please. So the challenges, we have issues with internet connectivity, especially in the remote areas, because these sites are actually in the remote sites with limited mobile network connectivity, and limited IT skills among end users to input EQ results online was also a challenge that we noted. And because the Truenat devices were not connected to the remote connectivity solutions like Aspect, we actually had issues in terms of getting the results from the facilities. And insufficient training of EQA testing to end users due to poor internet connectivity. They could not join the virtual training that was offered by SmartSpot. And because most of these sites are manned by microscopists with limited molecular biology skills and pipetting skills, this also had a bearing in terms of their performance. And we actually, when we analyzed our performance by size, we realized that the sites that were manned by laboratory technicians or scientists were actually performing much better throughout the 3 cycles. Next slide, please. So in terms of the next steps, the IDDS project will be ending by March 31, 31 next year. And this program will be handed over to the NTP. And the good thing also is that the NTRIO was trained by the Uganda SRO to be able to prepare panels for EQA, for Truenat, is always gene expert. And the MOH or NTP will continue to conduct refresher trainings and support mentorship visits. As part of the expansion plans, there are plans to even procure more gene expert instruments, Truenat instruments. So these will actually be handy. The experience from this implementation also actually assist in shaping the expansion plan by the ministry. Next slides. So in terms of the lessons learned, the good teamwork with the Ministry of Health ensured that sites received their panels on time. WhatsApp platform also served as a platform to inform sites and remind them to test and submit their results. Although there were some challenges with some sites, and the remote guidance from super users improved the competence of the end users, as shown by the improved performance. And we also managed to provide certificates as an acknowledgement of participation and performance during the end user training that we did. And this actually helped them in terms of the motivation to even perform much even better. Next slide. I think these are just pictures from the field. Thank you very much.
Thank you very much, Ebert, for your presentation. We'll move to the final presentation, which is by Joel Kabugo. Joel is a TB disease research specialist at the Supranational Reference Laboratory in Uganda. He currently serves as the proficiency testing coordinator for Gene Expert and Truenat proficiency testing schemes, as well as operational research focal person. Joel is an expert in designing, implementing, and overseeing epidemiological research projects focused on TB, with work published in the areas of TB disease surveillance and quality assurance. Joel, the floor is yours.
All right, thank you, and good day to everyone. I'm going to take you through our proficiency testing for Truenat, ensuring quality testing for a new TB diagnostic POC, and we are going to look at the validation and rollout as done at SL Uganda. Next. So the background is that limited access to WHO recommended rapid diagnostics and the impact of COVID led to a widening gap in TB case finding. So to cover this gap, in Uganda, a total of 40 Truenat dual systems was introduced in the laboratory network. These were installed with support from USAID, with challenges of ensuring quality of results. The IDDS project supported Uganda with proficiency testing that were obtained from SmartSpot. So for sustainability, the Uganda NTL initiated an in-house testing scheme for Truenat. Next. So looking at the development approach we did is that we were already providing dry tube specimen for Gene Expert. So we went ahead to do the validation testing using the preparation method was the same. Then we scored the panels, which we did in the validation stock pilot. Then we did expert and advisory review, and then full scale rollout. So I'll take you through the details of all this. Next. So the preparation, what we did is that we started with 8 well-characterized strain of MTB that were retrieved from our permanent stock in storage. These were then cultured on Megit to multiply them to sufficient amounts needed for the validation runs. So we did perform purity checks using LJ and 7H11 media. Then we also went ahead to understand whether this is a MTB or non-MTB using the ST bioline. And then the colonies were also then inactivated to make sure that whatever we are setting out is really safe. So the inactivation was for 1 hour using Cotier oven. We did again do verification of the inactivation, and this we ran for 84 cycles, 84 days. That's a total of 2 cycles in the Megit machine. So after this, we did after this we prepared 5 mils of a 1 to 10 microdilution per strain, and then for each strain we went ahead to do a pre-testing of this on the Truenat system. Next. So under the panel treatment, out of the 5 MTB strain with the most appropriate mean and standard deviation from the pre-testing results were selected. And then the selection included 2 pan-susceptible, 2 MTB resistant, and then 1 MTBC. So adjustments in the dilutions were made for us to obtain a strain of medium reading when you look at the MTB plus probe. So 100 microliters of diluted inactivated bacilli were then prepared and aliquoted in 2 respective tubes, which were dried in the biosafety cabinet for 7 days before dissemination for testing. So each participating site received a panel that consisted of 5 samples, along with summary of instructions and a result reporting form. Next. So these are some of the results of our validation, and my interest is to draw you to the MTB plus probe, whereby we wanted to look at the cutoff, and we had set a cutoff of the main cycle threshold to be 22 in our validation result, and to have a SD of less than 3, with a coefficient of variation of being less than 10. So this was to ensure that our consistency is good with the homogeneity in terms of homogeneity and stability of the sample. So looking at all the different 5 samples which were sent out, when you look at A1, the SD was 1.99, which is strictly less than 3, which also you look at A2 is 1.5, A3 is 0.5, then F4 is also 1.3. So all the samples showed good standard deviation of less than 3. That's a miss. Then this concluded that the consistency and precision of the samples and the testing protocol of the Truenat was okay. The coefficient of variation was less than 10 of all samples, which showed the high repetitiveness of the preparation protocol and of the preparation testing and the protocol performance. Next. So we went ahead to visualize these results. We wanted to look at how were they deviating. So here we plotted the different probes. That is as per the Truenat MTB DX RIF, and then you're looking at P2, P1, and the control to see if there is much variation among the resistant samples during the validation, and this showed that there was consistency. There was not much deviation, and the samples did not scatter so much from one another over the different testing from the different participants. Next. So in terms of homogeneity and stability, what we did to make sure that we get the best out of this is that test samples were selected randomly from the prepared batches and quality characterized on Truenat MTB Plus and the MTB DX assay. So the characterization results are to give 100%, and in case we fail this, we had to repeat and test again. So key is that procedure aspects included regular vortexing during the RIF voting. So in terms of stability, is that panels were stored at 2 to 8 room temperature and at 37, and tested at regular intervals through the round to ascertain stability. So 3 panel sets were tested at 2 weeks interval up to 6 weeks, and during this testing, we never saw any deviation in the test values in terms of standard deviation and mean. Next. So the instructions for the rollout included that after panel validation, a full scale was sent out to the 40 sites. So panel preparation for the procedures undertaken during the validation. So to the sites, they had to add 2 drops of liquefaction buffer to the panels, then incubate at least for 10 minutes. And then this was followed by adding 2.5 of the lysis buffer to the tubes and inverting 20 times. So the waiting was for 5 minutes until sample was completely liquefied. So then transferring all the contents and loading the cartridge into the true prep for testing. So after this, pipetting off of 6 microliters of the purified DNA was followed to complete the testing. So this was the instruction that followed the full rollout. Next. So then this is part of the report form we designed. We designed it in such a way that it can capture all the details, including CT values, including when the person received the sample, when they tested, and also to capture all the details of the lot used, and also looking at the lab codes, and then when the panel was received, so that we know what's the difference in turnaround times, and then what is the cause of the delayed testing to some sites. Next. So the scoring system, we set it in such a way that MTB and RIF, if it's correct, we score 18 points. Then both MTB and RIF are incorrect, the score was 0. If you get an invalid error or no result, so in a case that is uninterpretable, you get a score of 5 for attempting to do this. Then if MTB is correct and RIF is indeterminate, a score of 9 was awarded. If MTB or RIF is missing, the score is given 0. Then complete recording of kits was given 3 points, and then complete recording of a reporting instruction and PCR analysis dates was given 2 points. Then complete recording of cycle threshold was given 5 points. So this was to make sure that we have a comprehensive capture of the pre-analytical and the post-analytical steps. Next. So the participation showed that sites did not return results, and some of the sites that did not included reasons like non-functional machines. Then we had some sites that were transferred from the actual site where we send a panel to another site. So that brought in challenges. And then for a participant to obtain a satisfactory mark, a total of greater than 80 had to be obtained. So for all those that returned results, we had satisfactory score of 82% of all the participants. And then unsatisfactory was at 18%, which is just 5 sites of all those who reported back. Next. So we also looked at the turnaround time, which is a key factor in terms of also looking at patient care. The average time to receive PT from the dispatch date was 14 days, while to submit results was 10 days from the date of dispatch, as can be shown there on the scale. Next. So what is our take home is that DTS can effectively be used to prepare Truenat when proper homogeneity and stability tests are well performed. And then in terms of instructions, you need to create easy and precise instructions to follow. And then it's also possible to prepare one stock of PT panels that can be used to provide more than one PT round per year. This can be achieved after performing a stability experimental study. So then PT or participation in PT requires coordination, which is key in ensuring that enrolled sites adhere to instructions and timelines. Next. So we wanted to include an implementation approach for us to see how technical assistance can be given to countries. So key to start off is that there is need for staff training in Truenat PT preparation. And here we can look at the protocols. We can, the SIL Uganda can give on-site and off-site training for preparation of DTS, customizing it to Truenat. Then you need to do needs analysis to ascertain required resources, the materials and reagents. Then you need to develop SOPs and forms, as also this includes the analysis SOPs and also probably inclusion of creating an online platform that can be used to send and receive reports and results. So then next can be obtaining resources that include the standard reference materials, includes also reagents. And then you can do your pilot preparation and rolling out. Key is that you have to also keep continuous training and competence assessment of all the people that have been trained, and also recruiting more to make sure that you have a competent team, a bigger team. So after that, you need to do your verification and validation of the PT preparation methods and also the data analysis tools to make sure that whatever you are doing is conforming. Then you can do a full rollout to all sites. So finally, you can look at aligning the practice and procedures to ISO 17. Currently, we have the 2023 version. Then if all has been done well, you can apply for accreditation. But key to note is that you need to maintain continuous training and competence. But for sustainability, you need to always keep an eye on resource mobilization to ensure that your panel is being facilitated well. Next. Thank you.
Thank you, Joel, and I appreciate the work that Uganda SRL is doing on the panel testing. So we have about 5 minutes for Q&A. We're also able to stay on a little bit longer past the hour to try to answer any additional questions. I think maybe one of the immediate questions we have is about the sustainability of this project, as well as the activities associated with it. Maybe my first question might be to Joel in terms of Uganda's capacity to manufacture PT panels for other countries, or the ability to assist other countries to make their own panels. Any thoughts on this?
Thank you very much for that. So in terms of capacity to provide for other panels, we've been reliably doing this for other schemes. For example, GeneXpert. We support over 536 labs. We support networks from different countries. So in terms of the rounds, we are able to prepare at least 2 rounds in a year. So we always target between the month of Feb and August to send out this. And for Truenat, we can also liably support any countries. Then also in terms of training, we can be able to build capacity for them. We have an accredited training course here, which is whereby also Truenat is already included on the training menu. So we can accommodate people to train from here. And if the country prefers to have an on-site training from that side, we have enough human resource that can do that. Does that cover the question?
Yes, Joel, and would you mind if we include your contact for individuals who are interested in reaching out to Uganda?
Yes, that's okay. That's for sure.
Excellent, thank you. So it looks like also Tanzir had a question in terms of the ability to support the EQA. As we know, this is project funded, and trying to understand what sustainable supply of PT support looks like. And I think this is a very important question, Tanzir. As we know, countries have great interest in rolling out Truenat, and generally for EQA, what the process is for support. I think it's a worthy question, and certainly USAID is committed to ensuring that testing is done in a quality fashion. And so we are looking to support countries, and Uganda, I think, provides a sustainable model for support in the region. But obviously, we look to others as well to take up the commitment to quality testing. And so we definitely need to find opportunities and resources where it previously didn't exist to support this. So your question and comment is noted, Tanzir, and we certainly will continue to focus on this for future rollout of diagnostics. I think we're at the top of the hour, and it doesn't look like there are any additional questions regarding the EQA piece. If there's anyone,
so Kaiser,
yeah,
I think you may not have the hosting rights to actually see the Q&A box, but there are a few participants have asked questions there.
Sure.
So if people don't mind staying on for a few minutes. So there were a couple questions, I believe would be directed towards Eric Reisdorf, just about the IDDS EQA program. So the question is about the super users and the end users that are involved in the EQA program. Are they both lab people, or were there people that are not lab people without that background but trained to use Truenat?
Great. Thanks, Wayne. Yeah, so that's an excellent question. So IDDS worked with the IDDS country teams and with the national TB program in each of the new tools countries to identify national and district or regional level laboratory staff that had experience working with GeneXpert, and that may have already been super users for the GeneXpert network. And then we took those pool of experts and trained them on the Truenat system, which was IDDS had developed a super user training package that we rolled out in these countries, and to train those users to be able to support the Truenat sites. And then we also, as I mentioned, included EQA in the training, because we realized early that during the pilot that there were a lot of challenges that the sites had because they weren't familiar with the EQA process, and many of them didn't have access to the internet. Thank you.
Thanks, Eric. The next question, I'm not sure if this would be to you or to Han. It's about the QR codes. Could you just share a bit of information about how they were developed to prevent sharing of results between laboratories?
Sure.
And were these samples also labeled?
Yeah, so each sample, each of the 4 samples per cycle, each had a individual unique QR code label that was affixed to the sample strip with a sort of a removable sticker. And that each of those samples had a unique ID. So of the, let's say we sent 30 panels of 4 samples each to a country, then each of those 120 DCSs had a unique barcode, and only SmartSpot had the key. So they were the only ones that knew what the results were. So there was no way for laboratories to be able to, work with each other on samples, because the sample numbers were each unique.
Okay, and I think the last question to you, the question is, how many samples were sent to each site, and how were they identified in a certain country or in all of the other countries?
Yeah, so each of the cycles, all 3 cycles per year, were sent to the sites in using the sample referral system that was already established for TB, and they were delivered to the sites, and we tried to include all 3 cycles in the same shipment to the countries to keep the costs low, so that we weren't doing shipment after shipment. Hopefully that answers the question.
Yeah, I think so. Okay, the next question is asking, was training given only for EQA testing or even for routine Truenat testing as well? So I can say a few words about that. So under this Introducing New Tools project, so this was a joint project between Stop2B and USAID, and in the countries there was a very significant role being played by the IDDS project, as well as by the implementing partners of USAID missions, and they certainly provided extensive support for routine Truenat testing, both for the end users as well as for in most countries there were also a trained pool of super users that were trained to provide supervisory supports and mentoring for other Truenat sites. There's also a question, I believe this was asked during Joel's presentation. Could your expert MTB RIF PT panels be used for Truenat EQA?
So this is I think because when you look at a one-stop panel can be prepared, but key is that you need to do the validation before you send this out, because you may find a variation in terms of the cycle threshold. So the best thing is that if you are to do a one-stop panel, you must make sure that you target the medium range on both platforms.
Great, thanks, Joel. And I think just related to one of the questions that was in the chat box from Alejandro about ISID resistance detection, I just wanted to comment that the MolBio platform, they do have a test now for ISID resistance detection, a chip, but it's relatively new. It is registered and certified for use in India, but it does not yet meet the international quality assurance standards that would allow for procurement. And for that reason, since it is new, we were not able to include it as part of the Introducing New Tools project. So the Truenat testing that was done, it was for detection of MTB and for rifampicin resistance only. So that's why the EQA program was developed accordingly. So I don't see any other specific questions, and we are a few minutes now over. Any last comments from your side, Kaiser?
Nope. Thank you, Wayne.
Okay, then thanks everyone. As mentioned, we will be sharing with all of the participants as well as people who registered links to the recording as well as to the presentations. And if you'd like to reach out to any of the particular presenters and you didn't catch their email addresses, then feel free to reach out to Kaiser or myself, and we'd be happy to make the links. So thanks again to all the presenters, and thank you for joining us today. Goodbye.